Good morning, all. Happy Teachers' Day to all my dear mentors, teachers, and colleagues. Before we start the program, I'll call upon our dear chaplain HN to lead us in prayer.
Shall we all stand for the prayer, please? In the name of the Father, Son, and the Holy Spirit. Our loving Heavenly Father, we thank you so much for the first Thursday of this September. Thank you that you brought us together in this fashion to hear something very new. Also, we pray for Dr. John Valliattu as he's going to share his burden. We may be able to understand it, accept it, and that will be a blessing for our institution and for our nation. Rest of the time we commit into your mighty hand. Lead us and guide us. In Jesus' mighty name we pray. Amen. Please be seated.
On the special occasion of Teachers' Day, we are truly honored to have a true teacher and mentor, our dear Associate Director, Dr. John Valliattu, to share the quest today on this special topic. On this topic, I am so lucky, I am so OCD. John sir is a leader who brings great passion and insight to everything he does, and today's session will be no different. The topic is a surprise, but I am sure it will be quite engaging and a learning aspect for all. Thank you. Shall we all welcome Dr. John for this quest?
Thank you, Dr. Abel, for that introduction. A very happy Teachers' Day to everybody. I know this topic is an enigma. I'm not a psychiatrist, but I hope things will become clear as we go along. I'm here not as the Associate Director or Head of Cardiac Surgery, but I'm here as the Chairperson of the Infection Control Committee, and most of my colleagues in the committee are here. Thank you very much. And I owe this talk to them for collecting the data and producing very interesting observations. Yes, I have always been OCD from my childhood, and I got into trouble with it. I used to fight with my mother when I was 7 or 8 years old because she used to cut, when I saw her cutting meat and fish, and with the same knife cutting vegetables. I fought with her. I said, "You shouldn't do that, you should wash in between." And I got into trouble with my wife after getting married because when she was making chapatis on the counter, the flour used to fall on the floor. And I used to fight with her, say, "Why don't you put it 5 centimeters backwards so that the flour doesn't fall down and I don't have to come back and clean it?" So I've always been OCD. And maybe that is why I became a surgeon and did a lot of hand washing in my work, scrubbing, hand washing. And don't think that all this hand washing has given me a false sense of righteousness. But something which happened is I lost my fingerprints. When I go to the US and the immigration person looks at me, "Is that you?" Yeah, my fingerprints don't come. And when I try to check in here at the biometrics machine, and I put my finger many, many times, and no response. No response. And then I try to tell the machine that I'm Dr. John, I'm here day and night, and I do so many surgeries. I'm Dr. John. But the machine, these days we have artificial intelligence even fed into this fingerprint machine. And the fingerprint machine gets back at me saying that I have never known you. Depart from me. I have never known you. So this is my face with my fingerprints. But let me get my remote control. See, it's all about hand hygiene. It's all about hand hygiene. And there's one simple thing which I want all of us to do. This message is not about the whole topic of infection control and the various bacteria and antibiotic resistance and MDROs and all this. No, this is about only one thing. One thing we are failing to do, that's hand hygiene. I'm sure you are all familiar with this verse in Exodus. And this hand hygiene thing didn't start these days. It started about 2,000 years ago with Moses. And it is one of the dictums given to the Jews. They shall wash their hands so that they will not die. This is to be a lasting ordinance to him and his descendants. So it was given to us about 3,000 years ago so that we may not die, so that our patients may not die. And this is a lasting ordinance to all of us who are the descendants. Now this thing, as I said, it started 3,500 years ago. But seriously, in medical profession, it started with this guy, Semmelweis in Vienna in the 1840s. And they had two labor departments, and one was run by medical students, and the other was run by midwives. And the medical students used to go to the autopsy room, and then they used to move into the labor room, I suppose without washing their hands. I don't know how they could do it, and they conducted the deliveries. And the maternal mortality from puerperal fever was more than 10% there. And where the delivery was conducted by the midwives, the mortality was only about 2%. Still, it was 2% in those days, the pre-antibiotic era, and before the germ theory of infection. So what happened is one of the colleagues of Semmelweis cut his finger in the autopsy room. He got an infection and he died. And when they did an autopsy, they found the same findings in his body like the women who used to die from puerperal fever. So he associated these two, and he said, let the medical students wash their hands in chlorinated lime. So he tried that, and the mortality fell tenfold. So that is the beginning of the modern hand hygiene. Now, how are we doing in BCMCH? And my colleagues here in the infection committee has collected some data, and they have shared it with me, so I want to share it with you. In my previous experience, in the previous hospital I used to work in, the best hand hygiene data, the best hand hygiene practice was from the OBG and also from the colorectal surgeons. I was amazed why it is so. And I suppose it is because they deal with apparently or obviously not so hygienic, dirty part of the body. So they are compelled to do hand hygiene, hand washing. But we have some surprising data here. I am not going to talk about MDROs or anything. I just want to give you these numbers. That is my purpose today, just give you the numbers. So this is 2024 data. And as you can see, we have more or less a steady infection with MDROs, about 30%, infection. And the MDRO rate is, I think they calculate it by taking into account the number of admissions and the number of MDROs and multiplying with 1,000, right? So these are the MDRO rate is 2.8%. It's about steady at about 2 to 3%. In 2023, as you can see, we had less numbers. We were better in 2023. And it's obvious on this slide, they've given me a slide where we compare 23 and 24, And the blue is 23, and the red is 24. And as you can see here, we were doing much better in 23. I suppose the reason is that we no longer fear COVID. We think COVID is gone, and we relaxed. So we haven't developed a habit which is lasting. We haven't developed a habit. We haven't become OCD, which we should have. Unless you're OCD, you cannot maintain this habit. I don't see any of my psychiatric colleagues here. I wish they were here. But they say OCD is not a good thing. But for me, OCD about hand hygiene is a good thing. And as you can see, we have data until July. August and September we don't have. And our MDRO rates are much higher than in 23. So when you compare MDRO rates, 20 and 23, again, you can see that we are much worse than last year. And these are the MDRO categories, respiratory, blood, urine, and exudate. And the maximum here is the green one, which is the total, that's the total. And the respiratory is standing above all the others. At this time, look at the blood contamination and the blood MDRO cases. And we have a large number. We have a large number of blood contamination from the total MDRO cases. At this time, I would like to invite my friend and colleague, Dr. S.K. Matthew, to share with us some heart-rending stories. Dr. S.K. Matthew, can you come up here, please?
Respected Achan, respected John Valliattu sir, senior colleagues, friends, and my dear students. What we just started to listen was a brilliant piece of advice and documentation from our beloved John Valliattu sir. Well, I always knew John Valliattu sir from my early days as a youngster. He was a brilliant doctor, and he used to come to my dad's hospital and take charge of the hospital whenever we used to go out of the town. We always used to appreciate his gentle, smiling demeanor and his polite, professional approach to patients. Thank you, John sir, for calling me to share some experience about MDRO infections. Now, as we expand and advance and try to reach newer heights, we should also remember that right in our wards, we have very resistant, severe infections which may kill and harm our patients who came for something else, depending on us and depending on the prestigious BCMCH. I just want to elaborate very briefly about two patients who are with me in M2 unit and for the last 2 weeks. And it's not a singular or it's not a particular incident. It may be there in every ward, every specialty. Now, the first patient was a 71-year-old male patient who was admitted for dengue fever. He had severe dengue, and his platelets and counts dropped, and he went into hypotension. But however, we were able to manage him, and by the 5th day, he was better, and we were about to discharge him on the 6th day. But on the 6th day, he developed high fever spikes, tachypnea, drop in saturation, and we had to shift him to the ICU, and his biofare pneumonia panel showed resistant Klebsiella infection and E. coli infection. Poor fellow, ultimately, he also developed MI, non-ST elevation MI, and shock. And this non-ST elevation MI was attributed to secondary MI. He was on 4 inotropes, but unfortunately, he passed away. The second patient was still older, 81-year-old male who had CVD and a residual hemiplegia. He had a catheter, and he had a catheter-associated UTI and pyelonephritis. And we were treating him, and we gave antibiotics for nearly 8 days, and he recovered. And the 10th day, we were about to discharge him. All his son was in Ireland, and they were all happy that he was going home. But on the 9th day, again, the same symptoms, breathlessness, cough, drop in GCS, hypoxia, and he was also shifted to the ICU. Then, by God's grace, we were able to shift him back to the ward. He's still in the ward, not fully recovered, and still not out of danger. What I have to say is that it is there lurking in our wards, and we have to be aware of, as John sir correctly said, about simple things like hand hygiene. As a concluding remark, I would like to say that to remember the 4 I's of MDR infections. First is identification, I. Identify the patient, identify the ward, identify the organism. The second I is isolation, definitely isolate the patient. And third I is instruction. You should personally instruct whoever concerned, whoever is interacting with the patient, you should instruct. And last is implementation. You should not only instruct, but see yourself that all your instructions and the infection control instructions are being implemented. Thank you, sir.
Thank you, Babu. I was not talking science, I was talking philosophy. And I was talking psychiatry and psychology. But thank you for talking science, Dr. S.K. Matthew. And as he said, his father was our family physician, and his auntie, his brother, mother's sister was my classmate. And whenever his dad wanted to go to Madurai to visit his parents, even when I was a medical student, 3rd or 4th year medical students, I was scared. He used to ask me to come and do his hospital. And I honestly was scared to death. But I couldn't say no. That was, I suppose, it was good education for me from that time onwards. Moving. Okay. Now, these are some more data about the source of the infection. This is the infection from the exudate. And again, it's science. You just have to keep in your mind and understand that this is a serious problem. You know, I don't want to talk science. I'm just talking philosophy. Now, at this point, I would like to invite Busy, our infection control nurse, come on stage. And who is going to demonstrate, Busy? We all want to learn and know what I'm talking about. You know that I'm talking about hand hygiene. And it's a good starting point that we know how to do it properly. And to demonstrate that to you, my colleague from the infection control, Jayalakshmi, is going to show you how to do it.
First step, palm to palm. Then right palm over the left dorsum interlaced with the fingers. Then vice versa. Again interlaced with the fingers. Then interlocking with the fingers, vice versa. Then rotational rubbing of thumb. Vice versa. Then clasp the fingers backwards and forward, backwards and forwards, backwards and forwards, vice versa, backwards and forwards, backwards and forwards, backwards and forwards. In hand wash, we are also including wrist. In hand rub, only 6 steps, and hand wash, we have 7 steps. We have to do at least 20 seconds. Hand rub duration is 20 to 30 seconds, and hand wash duration is 40 to 60 seconds.
Thank you, Jayalakshmi. Thank you. Now, that's a bit of too complicated science, isn't it? How much, how much did you absorb from that? But I always think that it's very important to have structural change, and I keep talking to Ajit, he's not here, about architectural change for behavioral change. If you have a bin kept in the room, people throw rubbish into it. If you don't have a bin, you throw it everywhere. If you have a line in the middle of the road, you drive on either side. If you don't have, you drive in the middle. So there should be structural change which promotes or which mandates behavioral change. And the first thing is to have a bottle of hand wash at the entrance to the ward. In our cardiology ward, my cardiac surgery ward, there is a bottle or at the entrance, at the nursing station. And as soon as I go there, I see it, and I do that, and then I keep doing this. She said 20 seconds, so you think it's too long, but I have enough time. I keep doing it, and the nurses come with me for the round. And by the time I reach, I don't do all days, but I'm obsessional because, so I cover all parts of my hand because I'm obsessional. So we may forget the science, but if you're obsessional, we cover every part of your hand which you think is contaminated. So I ask you to be obsessional. Do this. And I reach the patient, and I talk to the patient, I examine the patient, and there is a bottle at the patient's bedside. That is an essential structural change. There is a bottle at the patient's bedside. If it is not there, the clinician cannot do it. So yesterday I was in the CCU and there wasn't a bottle at the patient's bedside, and I asked the nurse, where is the bottle? And suddenly she went, there was one for the patient. She suddenly went behind and opened the patient's cupboard and brought it to me. So that's no use. It's like once upon a time, my good friend was traveling from USA to Trivandrum, and I was working in Muscat. And I had a house in Trivandrum, and I had told him that he could go and stay in my house. And I had a guy who was taking care of my home. So I told him, Shanmugan, you write Dr. Matthew on a piece of paper, and you go to the airport. So he went to the airport with a driver and a car, and Dr. Matthew came out, and he's looking for this paper with his name, and he doesn't see it. And Shanmugan is waiting for Dr. Matthew, whom he doesn't know. And finally, after everybody had left, only these two people were left in the airport at the exit. And then they thought, we are the people. And Matthew went to Shanmugan and said, didn't Dr. John tell you to write my name on a piece of paper and hold it? And said, yes, I have it in my pocket. He took it out. So there's no point in having it in your pocket. You must keep the bottle at the patient's bedside so that the doctor who is going to do the round can see it. And after seeing the patient, he takes that and he talks to his colleagues, his entourage around him, teaches, and goes to the next patient. And by that time, it is 20 seconds. You've done it. You have the time. You have the time. Keep repeating the process. And when at the end of your round, either the last patient has got a bottle, which you can rub your hand with, or come out and at the nursing station, there is a bottle of sanitizer which you can use. So it's not difficult. It is can be done. If we want structural change, we want obsession. These two things. These are the things I ask you to have today. Structural change where the hand rub is available, visible, and at the nursing station when the clinicians enter, anybody who enters, so they see it and they start hand rubbing, and at every patient's bedside table it's visible, or on the cardiac table in front of the patient it is visible, so that when he finishes that patient, automatically it has to be done. Now, let us look at the hand hygiene compliance. We've been talking about the infection rate. If you look at that, in 2023, we were much better. And in 2024, we are much worse. Among doctors, look at this, compared to the previous slide. That was all staff. See, some places, in February, there was 73% last year. But this year, it dropped to 37. And so among the hand hygiene compliance itself has dropped, but among the doctors, as you can see, it is dismal. It's very bad. We who should show the example are failing. And the nurses and other staff are doing much better. Now, look at this. Isn't that amazing? Neonatology, 100% partial and 97% complete. When they say partial, it means that they're not following this technique or they're not doing the complete 20 seconds. So they classify it as partial. But still, they are nearly 90%. But look down, the second is pulmonology. They are about 50%. And they have a lot of infection. Still, they are 50%. OBG, I expected OBG to be top. Honestly, Dr. Kunyam, I expected. My previous experience in other hospitals before I came here, OBG was always tops. And they are only 40%. General medicine, Professor S.K. Matthew, general medicine is only 31%. 31%. I think we have to improve a lot. When we cry about our patients' plight and our own plight, but are we prepared to change our habits? Are we prepared to change, and change with a passion, change with obsession? And look at my own colleagues, cardiologists and cardiac surgeons, 20%. I don't think that reflects cardiac surgeons because most of us are obsessive. The two of us only, I am obsessive. I think Kanan also is obsessive. ED, look at that, 17 and 12.3%. I hope you made a mistake in your numbers. I hope it is wrong, but I can't, because I can't believe it, that our ED physicians are very bad in hand hygiene. And hem-onc, only 50%, because they're 15%, their patients are at risk of infection because they all have taking chemotherapy, low counts, and 15%. General surgery, 14%, not at all good enough. And you come down, ortho, 13.3%. They also do implants, and they have to be extremely careful. Their theater is sterile, but their hand hygiene practices are very poor. And look at the ICU doctors. This is what Dr. S.K. Matthew was talking about. His patients go to ICU and they get these infections. And the ICU doctors, I don't want to put them down here, but I hope they will listen to this. I don't think anyone of any ICU doctors here? No one came, but I hope this message will get to them and they will make the necessary structural changes and also their psychological changes to improve. So at this time, our hand hygiene champions are the neonatology department. Give them a big hand. And I would like to invite Dr. Sumita, head of neonatology, on stage and honor her on your behalf. Please, Sumita, come up on stage. And I invite Dr. Renu to come and honor Dr. Sumita. See, this is new. Absolutely new. I'm just opening it. For you and your colleagues, we are honoring you. Thank you, Sumita. This is not the only thing. I'm buying you lunch, the whole unit. Okay? Thank you. Yes, you take your mic. Tell us how you do it. Tell us how you do it.
So we are a unit with newborns, so we struggle with their lack of immunity is the point that we start with. So they're not people who have a lot of immunity. They struggle to stay free from infection. They're preterms. So infection is something that we constantly struggle with, and our microbiology team will tell us about that journey that we have had. So we have had our share of infections in the ICU, and that is why the compliance rate is this high. And every time it sort of goes up, our infection rate goes up. We've had a lot of help from all of our departments, and we constantly work to keep infections down in the ICU, but I think it's a constant struggle. So the fact that you're honoring me, I take it with grace, but also I'd like to confess that we constantly struggle, but with help from all our sister departments, we are sort of moving on, and I thank everyone for the cooperation and support. Thank you.
Thank you, Sumita. You and your colleagues are a role model to this hospital. And thank you, Dr. Renu, for coming and honoring Dr. Sumita. And I must say, acknowledge the contribution of Dr. Renu and Dr. Reena and the whole infection team for preparing this data and helping me for preparing this talk. Now, this is a slide which was prepared by my infection control nurses. They wrote, "We are all responsible for infection control, and we are all responsible for developing a habit." And I added the note there. We are not all responsible for infection control. I'm sure you know this management story. Sudha is nodding, and I'm sure if my friend Rosie was here, I'm sure she would know this. The story of everybody, somebody, anybody, and nobody. So this is the state of affairs when we say we are all responsible. No, each one of us has to do it individually, not expecting that someone else will do it for us. Now, I would like you to be in a state of Ophelia, where she was crying, "All the perfumes of Arabia will not sweeten this little hand." But this is a famous painting by Sir John Everett Milius of the hands of Ophelia, when she was mourning and crying that she had committed a murder and her hands were full of blood. And she said that all the perfumes of Arabia will not sweeten these little hands. But there is something which will sweeten our little hands. We don't need all the perfumes of Arabia. We just need that little bottle. Now, the onus is on us seniors. Myself, Professor S.K. Matthew, Professor John K. John, Professor Jijo, and every one of us clinicians, we have to be the role model. We have to lead the way. If we do it, if the chief does it, the juniors do it. And the students, our students here, I want you to grow up as obsessional doctors, only about hand rubbing or hand hygiene, not about other things. I want you to be obsessional. And I hope our seniors, if each one of us, when we enter the ward, go to this little bottle like you go to a shrine, And if you go to a shrine, you go, first of all go and do pranam there. Similarly, we have to do pranam to this bottle. Start from there, and all the juniors will follow it. If you don't do it, they will not do it. So the onus is on the seniors to show the juniors what to do. So my call to you is, let us change. Let us all become OCD about hand hygiene. And remember the dictum from the book of Exodus, and they shall wash their hands lest they die. This shall be a lasting ordinance. And if we don't do that, we fall into the inferno. Thank you.
Thank you, sir, for sharing your valuable insights on hand hygiene and the unique practices. So, over to you for any questions.
Don't ask me any difficult scientific questions. Ask me about behavioral change and philosophy. I will answer. Okay. Yes.
It's not a question, sir. I really want to congratulate you, sir, for taking up this important topic.
Thank you.
And thank you for not putting a title saying it's about hand hygiene. I don't think these many people would have come here. So thank you for keeping that. And thank you for just dwelling on that, just one important thing. See, so many things are not in our hand. What comes from the community, it's not in our hands. The character of the patient, underlying risk factors, they are not in our hands. But this one thing is in our hand, and we should be doing it. And thank you, sir, because you say it, I think people will do it, sir. And thank you for that, sir.
Thank you for that important statement, Agency. As she said, the community-acquired infection, the misuse of antibiotics, the MDROs, and the things, these are not in our hands, as you said. But there is only one thing which is in our hands, and that is our hands. Thank you.
Thank you very much, sir. As usual, as expected, it was very nice, wonderful talk. And this seems like very small topic, very small issue, but you narrated its seriousness. But just, I would like to ask you a different thing, different point or perspective. The January and June number seems everywhere, 2023 and 24 seems high, even though the pattern may be, means hand washing may be less, means high also. But the, what will say, MDR, it seems very high. So do you think anything like climate, it's affecting on that?
It could be. You are the expert on that. I'm not. I said I'm not talking
January
science.
and June just
Yes,
always just high.
because you guys in the community medicine should tell us that. It may be possible. It may be possible.
Thank you, sir.
Yeah. Thank you. Thank you all for coming, and have a nice day. Thank you. Madam. Madam has a statement.
I think some of us would have been here when Dr. Luke sir was presenting about WAP some few months back, and you would remember that the top slot organisms were gut flora. So the gut flora has reached the WAP. That's a proof that hand hygiene is poor. And I don't want to speculate how gut flora has reached, especially in the Indian subcontinent. It is possible.
Yeah.
Then there is an intervention called positive deviance. And I'm glad that, I don't know if anybody knows here, but it was demonstrated here when you congratulated Dr. Somita. Positive deviance means when some attitude or anything is difficult to implement, when there are people who do it, you recognize them so that others will follow suit. Another way is to look at why people are doing it. Do they have a story? What makes them, what reminds them? What makes them to do it is a way of handling such issues. It's called positive deviance. Then, thought I had one more, I forgot. Anyway, these are the two comments I had to make. Thank you.
Thank you, madam. I think you brought out a very important factor when you said the gut flora are infecting the respiratory tract, and that questions our practice, our toilet practices, and the hand washing practices after going to the toilets, or is it from the same patient the gut flora is infecting after doing the patient's body care? Are we giving the respiratory care without washing in between? All these things have to be monitored, and these have to be looked at. And I suppose in future, our team would be able to do some more observations and see why the gut flora reaches the respiratory tract. And I hope that will bring us more data and more behavioral change from our part. Thank you. In the meantime, be obsessive. Be obsessive. Be OCD. Thank you.
Thank you, John sir,
Thank you.
for that wonderful talk and on infection control and on the unique perspective of hand hygiene combined with an obsession. So let's be obsessive and let's all give a big hands to Dr. John. Thank you. See you next week for the quest.